Hi, everyone. Thank you for joining us today. I just want to introduce myself. My name is Dr. Paige Gernt, and I am just right across the street at Diana Health and OBGYN Associates. And I am an OBGYN physician, and I think you may know some of my partners, Dr. Cole, Dr. Adicott. I have 4 midwives with us and 2 nurse practitioners. So just wanted to kind of tell you who we were. And, kind of wanted to start this year off with some community discussions about more preventive health, and it is cervical cancer awareness. And I was telling somebody that I think in January we all start, of course, saying we're going to make a resolution, and it does seem that a lot of times that's diet and exercise, which is great. But I also wanted just to focus on taking care of you, taking care of the entire person, the entire woman. So I entitled my talk today, Do I Really Need a Pap Smear? And let's sort of go through things. I think a lot of people like numbers. So here we go, okay? What we want to do today is discuss the incidence of cervical cancer in the United States. And of course, telling you how many cases there are, how many actually deaths there are from cervical cancer. Etiology, I think you all know that means cause. I mean, have we really gotten down to the cause of cervical cancer? Risk factors, of course, a big issue, things that if you saw that you were doing that you could maybe change. Also symptoms that maybe would bring to your attention time to call the physician or your nurse practitioner. Again, prevention, what can we do to kind of stamp out this disease? How do we diagnose it in the office? And I'll go through that with you. And of course, recommendations and treatment. And I didn't say, of course, we can do questions however you want to. We can do it at the end of the discussion, or we can, of course, you can stop me anytime. I don't mind.
Yep.
All right. So here we go. I think you can see that there are approximately 14,000 new cases of cervical cancer diagnosed in the United States every year. And this was a number I, of course, received from 2022. And of those 14,000, approximately 4,300 will pass away from cervical cancer. And I wanted to really kind of put this in perspective because now it's about the 14th most common cause of cancer in females in the United States. And they really do rank these. I think most of us would think as the top 3 would be more like lung cancer, breast cancer, colon cancer. So you see that cervical cancer has fallen way down on this list. So we must be doing something right. I guess that's what I'm saying. It was 1 or 2, the first or second most common years ago, decades ago. And I also wanted to make sure that you notice that I said the United States, because in developed countries such as the United States, cervical cancer is very low, but in our very underdeveloped countries, it is still very rampant. So let's look here at, this is, again, I think people do better when they have a visual. And this, of course, you see, it is just a steady decline. And that is what we'd love to see in every cancer that we had. But I think what happens is people say, well, okay, so tell me what happened. And so I brought this picture up because this is a very important man, and you all will understand once I tell you the name, okay? His name is Dr. George Papanicaloau. And I think that's a very long name. So we don't call it the Papanicaloau test. We call it now the Pap smear. And so I think people really do, and they really like kind of medical history to understand where names came from. And if you really pay attention, you'll see that the word, when you say Pap smear in a chart, is actually capitalized because it is after his last name. He was born in Greece, and it's really interesting. He's always had a biology background. And he was really striving to get to the United States. And when he first came to the US and immigrated, it's really interesting to read the history that he waited tables, he played violin in one of the restaurants. But finally, thank goodness, he got to New York, where he did work in a biology lab and started more of his medical training. And then in the 1940s, he did realize that you could take a sample from the cervix or the female vaginal canal and look at those cells on a slide and definitely determine if they were abnormal or not. And throughout the years now, this is the standard. And we are able to detect over 90% of all cervical cancers by using the Pap smear. If you read a little of the historical data, some of his, I think, partners don't ever get mentioned. So there is one called it's Babes, B-A-B-E-S, we would say Babes probably, and Dr. Welsh. All right. So just wanted to, this is the female anatomy, but I knew I would be talking more about this today. So of course you see that the uterus is there, and then that goes down into the cervix. The cervix is the opening to the womb. We all know that as females that have maybe had a baby, that the cervix is what dilates. But of course it's very small when you're not pregnant. We can see that when we examine a patient as we look into the vaginal canal. So the cervix, when I'm examining somebody, looks like a very small round object with an opening. The opening is called the os, O-S. And I really wanted to put that up there because I'm not sure a lot of people know what we're seeing when we do their exam. In the collection of the Pap smear, of course, we use the speculum. I have a metal speculum placed there in the picture, but I think, a lot of us have turned to more of a plastic one. Some people find one or the other more comfortable. We do have both in the office. Then to collect the sample of the cervix, you use something called a spatula, brush, or broom. Again, just trying to give you a little bit of visual of what we're using. Then that specimen is now sent to a laboratory. So it's not that I look at those. I wanted to make sure I explained that too. And then a report comes back to me and I review what the pathologist or cytologist said. And then that's when you get a report. I did want to mention, though, that the Pap smear is really only part of the exam. That, of course, is detecting the cervical cells, but I put pelvic exam because it's very important that we have that also. That's how I visualize things. That's how I palpate. Like, do I feel a raw area? Do I feel a nodularity? Do I feel a mass? All right. Okay, so etiology. We said we were going to talk about, have we found a cause? Well, it's really quite exciting because we really have. The majority of abnormal Pap smears in cervical cancer are related to HPV. That, of course, is what we say in the office, but HPV is the acronym for human papillomavirus. And I think what's interesting, we didn't know that for years, and now our labs are easy now for us to order HPV in addition to the Pap smear. We have realized now that there are more than 150 strains, and they now are even able to break those out into what are low risk and high risk strains. A little bit more just to explain that, low risk strains of HPV would be what would cause genital warts. And all those genital warts are very annoying for most individuals. Those low risk strains will not then turn into a higher risk or a cervical or vulvar cancer, where of course your high risk strains are the ones related to cervical cancer. And we're saying cervical, but of course we have to realize that we can have vulvar, meaning vulvar, for those who are maybe not used to that word, that kind of encompasses the whole female outer region, like the labia, the perineum, the perirectal area. We've of course said vaginal cancer, and then of course HPV is related to penile cancer as well. So risk factors, these are the ones that we can hopefully make a change that we would lower our risk of cervical cancer or abnormal pap smears. So the first one, like we say, is human papillomavirus. But then what makes human papillomavirus more apparent? Well, the first thing that we talk about a lot is smoking as a risk factor. And I don't think it makes a lot of intuitive sense to people who are like, now, how is smoking related to cervical cancer? But if you think of HPV as a virus that is a carcinogen, it can cause a cancer. And then we have smoking, and we all know smoking chemicals can be carcinogens. So it's almost, if you will, making it a double whammy. You've already maybe injured one cell, and then you've got another assault to that cell, if you will. Of course, HPV comes from sexual contact, multiple sexual partners, because you may be bringing a lot of different strains of that high-risk HPV into the relationship. Lack of condom use. One that a lot of people don't realize is that, again, think about it, HPV is a virus. So anything that makes us not fight off a virus would, of course, be more worrisome. So your immunosuppressed patients, such as your HIV patients, renal transplant patients, that just gives you a little bit more idea of who we have to really make sure they're coming to get those pap smears, or maybe suggest their pap smears, recommend them a little bit more often. And then last one, which may have been very much put on the, should have been maybe put at the first of the list, was forgetting to have a pap smear. If you really talk and take a history on someone who's had cervical cancer, if you're sitting down with them, most of the time, if you ask them when their last pap smear was, it would be 10, 15, 20 years ago. And I think people think, wow, how did it happen? But we all know that happened. So that was one I really wanted to kind of impress upon everybody. All right. Symptoms, things that we would want to have our patients call about, but I think you see the very first one is no symptoms. I mean, that's why, again, I have to keep kind of hammering the point that you have to get the pap smear, because you can have abnormal cells on a cervix and not have any symptoms whatsoever. Symptoms that we do always comment, if you read about cervical cancer abnormal pap smears, you'll see that some of the symptoms are random vaginal bleeding, bleeding after intercourse, abnormal vaginal odor. But I want to make sure that people don't get so alarmed with those all the time. I think we all know that we can have some random bleeding. Other things can cause vaginal odor, some discharges such as bacterial vaginosis, when the pH of the vagina gets off. Another one that can be pelvic or flank pain. I think when I say flank pain, I mean the side going around to the back. But again, a kidney stone can cause flank pain. So these get a little bit vague, but of course we want our patients to bring those up to us if those were new onset, for sure. All right, prevention. I was going to put pap smear in about the biggest font I could find, but pap smear is going to be right up there. But I think a lot of people may not realize, and people may, it's becoming more on the forefront that we talk about it, the HPV typing. So this is often done. It's reported on your pap smear, and you may not realize it's even being ordered. And we'll go over kind of who that's ordered for, but I want you to know that's really going to become more the standard. I think we're seeing it more and more that people even say, well, we eventually just need to order that off the pap smear to know if you're high or low risk. And then I wanted to talk just a little bit about immunization. I think most of us know there is a cervical cancer vaccine, if you will, but it's really an HPV vaccine. The vaccine is called Gardasil. It did roll out in about 2006. When it first came out, it was really You saw it more even in the pediatricians' offices, family docs, because it was recommended for girls 9 through 26. Of course, they have added boys to that now because of the risk of spread and the risk of penile cancer. The thought was to try to get them immunized prior to the onset of sexual activity. And then I think a lot of people said, well, wait, I kind of missed that window when it came out. So now it is recommended that you can have it up to age 45. I think the big thing a lot of people say, well, what if I've already been told I have HPV? It is still fine to get this because sometimes we still don't know for sure if the strain we had, if it's not real specified, could you still be covering some other strains? I get the question a lot about anything we do, of course, in testing or giving a vaccine. Most insurances do cover this. We check the benefits in our office before we give this. And then I think the question is, what is it? Is the proof in the pudding? I mean, has it really worked? And it has. I mean, I have now been practicing, I started practice in 2000. So here I am at 2023, and we really have seen a significant decline in the number of abnormal pap smears. Now, I think I still see plenty of abnormal pap smears, but I might see something with just a small or minor change on the pap, not this significant high risk, really concern about cancer. So it is nice that the data is showing us that the vaccine does work. All right, so this is kind of what a lot of people want to hear because it gets very confusing. 1 year you'll hear one recommendation, 2 or 3 years will go by, you'll hear another recommendation. I'm in my 50s, and when I was growing up, it was always you had a pap smear at 18 and you had it every year. So those recommendations have changed. Now we begin a pap smear testing at age 21. I get a lot of phone calls. It's not that at all a patient can come see me. I have patients come see me all the time, a lot younger than that, maybe to talk about periods, birth control, but the PAP, we usually start at 21. Age 21 to 29, now the recommendation is you can have a PAP every 3 years if the cytology, if everything comes back normal. Now, of course, if it comes back abnormal, there are definitely almost an algorithm of how often you would repeat that. The age 30 to 65, you can go as long as every 5 years if the cytology, meaning cells, are normal and you have no HPV, high-risk HPV that shows up. This is the one a lot of people don't know, and I'm going to talk a little bit more about this in a minute. If you are greater than age 65, or if you've had a hysterectomy for no abnormal PAPs in the past, then you do not have to have another PAP. Now, of course, this is where it gets real tricky because this is just talking about the PAP smear. And like we said, the PAP smear is just simply collecting those cells. So even though we might tell you it's fine to go 3 years without a pap smear, still the recommendation is to have a pelvic exam about every 12 to 18 months. I was going to let you all absorb that. This slide is probably the one most people kind of want to see right now. Now, again, we're still on this recommendations. Still, I have people that do not feel comfortable going 3 years or 5 years, and that decision can be made between you and your provider. I have some patients that absolutely want to come every 12 months. We actually even do the pap smear every 12 months. But again, I get the question, what about insurance? Right now, we've not had much problem with that. Maybe down the road, but at this point, we're not having any difficulty with that. And again, I wanted to make sure that everyone knew that if you've had a pap smear and you've had a long history of abnormal paps prior to that, or maybe you had a hysterectomy because of abnormal pap smears, you still perform a vaginal pap. So you take that little spatula and you swab the vaginal walls. So I wanted to make sure you know that that is something. So I always tell people, if you happen to move, go to a different state, and somebody said, oh, you've had a hysterectomy, you don't need a pap. Well, just make sure they know your history for sure if it were abnormal. All right, so we're going to move into a little bit if the pap smear is abnormal. So remember, a pap smear is how we screen the masses, as we say. Every woman, of course, I get all of these pap smears back, and we've got to make sure, what then do we do with this set that keep having abnormals? So we say if a screening test is abnormal, then you go to a diagnostic test. And so the test we typically use is a colposcopy. And I wanted to kind of go over that word. Colpo, C-O-L-P-O, is Latin for cervix, where maybe in the US we would say cervoscopy, but colposcopy has been the word for years, so we don't change that. And it truly is magnification of the cervix. And people ask me all the time, like, now, what am I looking for? Abnormal cells tend to be in patches of where I would see different colors, different vessels, what's called punctation, and just different patterns. And that's called mosaicism, just if you read about this. And then once I'm there magnifying, I have instruments that will biopsy both the outer part of the cervix and the inner part of the cervix. So we say ectocervix and endocervix. I think I've got a picture right here to show you. So I think you see the small picture under the normal cervical tissue. It's just a nice pink with a redder area, which that is sort of what I said. The outer would be the ectocervix, going into the canal would be the endocervix. The larger picture, we tried to magnify that because you see that big white spot, and that is called an aceto-white patch. And that, of course, was where I would take the biopsy. Now, let's talk about what we do with the biopsy results. Then the biopsy may be something very minor changes. And a lot of us, again, because we have good immune systems, we can almost kind of heal from a change due to HPV. Sometimes you can, I think the word is clear the virus. And so sometimes you're like, this is so minor. I think that, gosh, if we do nothing, maybe we'll do another PAP in a year and it would be fine. So sometimes it's just close surveillance with pap smears. But if there are cells that we want to, I guess, remove from the cervix, I wanted to speak about these procedures. The one a lot of people know is called a LEEP, and that stands for Loop Electrode Excision Procedure. So it is basically, I always say it looks like a little wand with a little hot wire, I guess, electrocautery. So think of this as a hot procedure, as we say, okay? And that actually shaves just a very small little layer off the cervix. I didn't want people to think that we're having to take a big portion of the cervix. It's very millimeters deep that these cells are abnormal. This is often done in a procedure room or an outpatient surgery. And a little sedation, because we would want people to be comfortable. And then cryotherapy, remember, cryo means cold or freezing. So you can then freeze the cells off. And the LEEP and cryo are pretty similar in what they're trying to accomplish. It's just, it seems this day and time we're using the hot procedure more. I think the LEEP is having a little bit better success. So cryo is a little bit older school, still could do it, but just maybe a little bit more your old thoughts. Then, of course, if we just keep having abnormal cells recur, there are times that we're like, this is really dangerous for you, and we're just going to go ahead and proceed with hysterectomy. Now, of course, we're pretty lucky we catch this very early, but of course, if there are times that we have spread, we have metastasis, then we have to go to radiation or chemotherapy. And I put referral to gynecology oncology there because a lot of people may not realize, and we don't have a GYN onc, as we call it here in Cookeville. And these are, of course, sometimes very subspecialists that kind of make your whole treatment plan. Now, the great thing over the years, I've gotten to know all the gynocs in Nashville, Knoxville, Chattanooga. And so they know when we call them, we've got someone they need to see. What they're really great about is they sometimes make the plan, and then somebody can have their radiation or their chemotherapy here at Cookeville Regional at our cancer center. And so my big conclusion on this was really, do I need a pap smear? And I think I'm going to say yes, 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 a million times. So I think that I just want to make sure everybody just remembers prevention is the key. Now, I have some other things to share with you, but I thought that might be a good stopping point for some questions. Not you just tell me, or
okay, let's see, let's go back, let's stop the share. Then does anybody have any questions? You can do it through the chat, or you can unmute and shoot your questions this way. Okay.
And if we don't, I mean, I do have a little bit more. We can stop there, guys. That was,
okay.
Oh, here we go. Yes.
Here's one. So 70-year-old, I no longer need a pap smear. How often do I need a pelvic exam?
Great question.
Okay.
And this is one of the things I wanted to make sure I do talk about. That's why I feel like it gets confusing. So most of my patients come somewhere probably after 65 for every 1 to 2 years for a pelvic exam.
Okay. Let's see. Another question. What can affect a woman from not having a menstrual cycle?
Okay, I want to make sure I understand. I want to really make sure I answer this, what you're looking for. Okay, from not having a menstrual cycle. Well, and I think, of course, that does go back to why we're not having a menstrual cycle. Sometimes, I guess a little bit more of a vague statement would be our hormones are off. I know we say that, but if we don't have our hormones, our estrogen and our progesterone secreting, where I guess we would think in a normal fashion to continue having monthly periods, sometimes we can go so long that then, of course, when you do finally have a period, we always say the floodgates open and it's an awful heavy period. You can actually go so long that the lining of the uterus can build up, and that would be called hyperplasia, and that can sometimes not be healthy for you as well. So if you go for a long time without a period, I think we do need to see you. We need to draw labs. I mean, could it be as somebody is going into menopause or kind of entering menopause a little bit earlier than they thought? And of course, the workup and the treatment for that would be different.
Okay.
Is there a screening?
Is there a screening for ovarian cancer?
So that actually, I had another slide on that. So the only screening at this time is, again, and this goes with going to get your pelvic exam, is to really have a good exam every year, because you want to make sure that we don't feel anything abnormal in an ovary area. Now, I think this is the tricky one. Ovarian cancer is one that is not as detected as easily. So a lot of people ask me, well, what are the symptoms? And again, the symptoms of ovarian cancer are quite vague. I think if you all have read about this, it can be abdominal distension, it can be bloating, it can be change in your bowel habits. But I think we know that's that can be very common in a lot of us. But I think it's one of those things, if those symptoms just continued, you'd want to bring it attention to your provider's attention. I think a lot of people want to know about the blood test, CA-125. There are some newer ones, HE4 and OVA-1. The recommendation is still not to use those as a screening tool. I do order them sometimes, of course, when people come in and have those symptoms, or if I see something abnormal on an ultrasound that would make my ears perk up, or in that way I kind of know where to continue the workup. Again, if I do end up having an elevated CA-125 or a tumor marker, I would get a referral, a consultation from the gyn-onc.
Okay. Let's see. Yeah, so let's see. Since I've had breast cancer, are my cervical cancer risks higher? Is that tied with the BRCA?
So I was going to say, you're right. It's usually breast and ovarian, and that's where the BRCA gene comes in. It seems like, we really do feel like breast and ovarian, even uterine, and even colon have more of a genetic risk, where cervical is really not. There's a little bit of thought that if everybody in the family had cervical cancer, many women, is there something in their immune system that might prohibit them from clearing the HPV? But really, I don't say that just because you have breast cancer that your cervical cancer is really increased.
Okay.
And then I think Haley had one.
What age should young girls begin seeing a gynecologist?
Right. So I think that one is always the one. It's wide open. Again, the Pap smear would not be till age 21. But again, I've had a 12-year-old come to see me to talk to her about periods. I've had someone who had difficulty placing a tampon and thought her anatomy was a little bit different, wanted me to examine. I've had a young girl that just wanted to talk about birth control, but of course not in front of her mom, maybe. And so those are the kind of things you can come see us for anything like that. But again, Pap smear wouldn't be till age 21.
Okay. Let's see.
Starla.
Since I am HER2 plus, I'm
am I at risk?
Okay.
Again, I really feel, like we said, it still is more that the cervical just doesn't play as big a part in that whole big scheme right there. Again, now we have to think, if you do anything to make yourself immunosuppressed, there's a whole other part of that story. Yeah.
Okay. Okay, so we'll go to the next section here. Let's see. Okay. Move that out of the way. Okay.
And this may answer a few more things for you. I did this. I didn't know how much time we'd have. Let's see here.
Not clicking. Okay, now try it.
There we go. Okay, endometrial carcinoma. And that, of course, we would all just usually say uterine cancer. And the reason I bring this up again is it's just something a lot of people ask me about. Again, what are the symptoms? Does it have a genetic component? But what I really wanted you to take away from this one is that the most common symptom would be postmenopausal bleeding. And just because you have some bleeding after you've ceased your period does not mean you have uterine cancer. But it is the one thing I would want someone to call me about. I feel like I hear this a lot when somebody has, a visit with me. It's more like they say, well, I didn't have a Pap smear. I didn't have a period for about, it's been 4 years ago and I started bleeding, but I had a Pap smear last year, so I thought everything was fine. And again, remember, your Pap smear really only checks your cervical cells. So we're talking about something coming from the actual womb or the uterus, okay? The reason, of course, it's called endometrial is that the lining of the uterus is called the endometrium, and that is where the uterine cancer usually starts from. Now, there are a few different kinds of uterine cancers, but endometrial would be the most common one. Again, you see it in the postmenopausal women. So of course, you're going to be seeing this more in your 50, 60, 70, 80-year-old. It's not that we can't have it in younger population. And I wanted to kind of explain some of that because you see the risk factors. The one I really wanted to talk about was obesity. And you see at the end, it says increased estrogen. So when we are obese, that means we have more fat cells, we have more adipose, and adipose is able to convert to more estrogen. And sometimes the more unopposed estrogen, not the right combination, again, I kind of alluded to this earlier, is that it will make the lining continue to build up. That's called hyperplasia. Hyperplasia, then the thickening can then start becoming what's called atypical, and then it can even progress to carcinoma. I put family history in there because definitely if you heard like a sister, an aunt, I mean, you do need to really let that kind of perk up your ears, because this may be more than just run of the mill. There may be a genetic test that this person needs. The workup, again, for endometrial or uterine cancer would be a pelvic exam to make sure I don't see anything odd. Ultrasound usually next to assess the size of the uterus. The uterus doesn't necessarily itself have to be enlarged, but the lining, as I said, there are measurements for the thickness. And this is well documented in just research and data, that if it's so many millimeters or over that, then you do get more concerned. Now, how to diagnose it, of course, is with a biopsy. And again, this looks like a small straw is how I explain it. Or a little papel is another word they use. And it does go into the uterine cavity. It can be cramping. It may not be the most comfortable thing. It can be performed in the office. Now, sometimes it's just difficult to get this procedure performed in the office. Maybe the cervix is difficult to open. So this is when we do then proceed to, say, the operating room, and we would do what we would all call a D&C. And D means dilate, open up the cervix, and curette means clean out the cervix. I wanted to maybe run back to that one picture. I thought this might give you a little bit more. Okay, so we're there. It really would be a straw that goes in through the vagina, in through the cervix, and into the uterine cavity. So I wanted to show you how that's very different of where we're taking a sample than from just the cervix. Okay, sorry, I'm gonna have to run back down through here. Okay, treatment, because the uterine cancer does start in the lining, that's the good news for us women, that it starts somewhere very confined, and it takes a long time, typically, most of the time, for it to go through the uterine muscle wall. So a hysterectomy is often the cure. And a lot of times there has not been any spread. Again, if there is spread, radiation, chemotherapy are available. We've learned again that radiation seems to be more beneficial, more helpful for endometrial carcinoma. And again, just because, like I said, we catch it so early and it's confined, that the survival rate is very high. All right. And again, please, if you have anything, we can do it. I'm just going to kind of touch on ovarian, breast, and colon if we have enough time. If we don't, we'll just stop. So takeaway message on endometrial: call for any erratic bleeding, postmenopausal bleeding. And really, when I was in school, postmenopausal bleeding is cancer until proven otherwise. I have to have some sort of pathology usually. Now, again, there are other things that can make you bleed when you're postmenopausal. You can have benign endometrial polyps. You can have vaginal wall tears as we become more menopausal and the tissues are thin. It really makes almost like little paper cuts, and there are creams and gels for that if that happens. So I don't want you to think everything, if you had some bleeding, would be uterine cancer. All right, we'll go into ovarian cancer. I think you see, I wanted to put these numbers up for you because they are very different than our cervical cancer numbers. Approximately 20,000 new cases each year, and then 13,000 will pass away. And I think you saw it was 4,000 pass away from cervical. And again, the reason is that once you start having symptoms, it seems like we've already progressed to a more advanced stage. I think we talked about the bloating, abdominal distension. We brought up again that really there's no great screening test, and this is what they're working diligently. When I read something about ovarian cancer, this is what they keep trying to come up with a better option for us. Again, risk factors, just aging increases our risk factor for ovarian cancer. If one article I read recently, if you live to in your 80s, your lifetime risk would be about 12%. Also, there's this theory of when your ovaries, don't have a break. That's a good way to say it, okay? They think it's the constant repetitiveness that the ovary has to work. So when we are during childbirth, our ovaries aren't ovulating. So this is a theory that why do you see it in women more often when they've not had a child? That's the theory. And then, of course, family history, again, can be a very big genetic link with ovarian cancer. I thought because we talk about breast cancer with ovarian cancer so much, we'd kind of do just some high points here because we go into the BRCA testing. Again, second most cause of death in the U.S., now easily detectable. Our mammograms, ultrasounds, MRIs, just really, we do a great job with finding early small changes on these images. And then, of course, survival on the rise. 5-year survival rate now, 90%. That when I started med school, that definitely wasn't that number.
Wow.
Of course, now I wanted to bring this up because you will read different things about when to have mammograms performed. So again, that gets a little confusing. I am an OBGYN, so I practice by what are called the American College of OBGYN guidelines. Now, that's not to say mine are the most perfect, but they will be a little different from, say, American Radiology Society or American Cancer Society. And I don't think anything, of course, is wrong. It's just that we just want you to get screened. I guess that's what I need to say. So age 40 to 50, most of ACOG will say at least get it every other year. A lot of women, get their mammograms yearly. Age 50 and older definitely advocate to get this performed yearly. Now, when you get to age 75, and some of the data says even into 80, do you need a mammogram? Well, I think the reason it says discuss with provider is that, thank goodness we're all just living longer and we have a better quality of life. So there are many women that know that, yes, I'm going to keep doing my mammograms because if they catch something small, maybe I would have just a small, what would be called lumpectomy, removing that area. And if you catch it that early, sometimes there's not even where you have to do more radiation or chemotherapy. So again, I know I sound like a broken record. Early detection is key. That's what we're saying on all of this. So BRCA testing. So I wanted to go into this. You'll hear people say BRCA, BRCA, but this is where There's been so much written about this, and we are just so fortunate now at Cookeville Regional, this area. We did not have a genetics counselor, and now we have one. And so if I'm in my office and I really am taking what we call a medical or family history, and we've had a sister with breast cancer, an aunt with ovarian cancer. I mean, you just start seeing some sort of pattern. You do worry about BRCA1 or 2. BRCA1 is a little bit more the high risk for breast cancer, but they both are risk for breast and ovarian. Now, the thing is, I used to often just order those tests from my laboratory out of my office, but now I tend to send these families to genetic counselors because they really do know if there are even other new variants, other things besides the BRCA that they need drawn. And of course, if you find out you are BRCA1 or 2 positive, I mean, this comes with a lot of big decisions. I think everybody can appreciate that, am I going to have a double mastectomy? Am I going to have my ovaries removed? These are surgeries. And of course, this would depend where you are in age and where you were with your ideas of childbirth and breastfeeding. All right, so I think this is probably the final one. I just wanted to throw this out because I talk a lot to women about all screening. So this is the latest hot off the press. It used to be that colonoscopy was recommended for women over age 50, for men and women, but now it is recommended age 45. So if you've not been told that, I mean, definitely bring that up the next time you're with your gynecologist or with your family provider. Again, risk factors, age, family history. Now, I put rectal bleeding, dietary choices. Now, we all know that somebody could have some blood in their stool from something as simple as a hemorrhoid. Again, I wanted to make sure I just have you bring this up if you've noticed this with your provider. So as I said, colonoscopy at age 45, but here's the little caveat. If you have a family history, let's say your father had colon cancer diagnosed at 50, you would have yours performed at 40. And then your GI doctor or whoever's performing the colonoscopy, because some general surgeons perform colonoscopies, they would then guide you based on how often those need to be. With the family history, sometimes it's every 3 years. Sometimes if they find polyps, it can be 5 years. So it's not the same for everyone. So don't let that confuse you. Get a lot of questions. A new thing is Cologuard. I think you all may see this advertised on TV. It is a kit that your doctor or provider would actually order for you. It comes to your home. And then it tells you very specifically how to get a sample of stool and send it back to their lab. Now, if the Cologuard test is positive, then you do need to go ahead and do a colonoscopy. If it's negative, they do think that test is good for about 3 years. The only thing to remember is that it is a good test. It is quite sensitive, but when I talk to the GI physicians, the gold standard is definitely still the colonoscopy, and a colonoscopy is something that could only detect very small polyps. And then the reason I bring it up is a lot of women don't see a primary care. Sometimes they just don't have many medical problems. So I just try to bring that up in my discussion of other screening. So, okay, here's the summary for our new year is all cancers now seem to be treated with early detection and we have a good outcome. So again, let's try to put preventive medicine in our thoughts and on the forefront here for 2023. But thank you all for joining me. And again, if you have more questions, I'd be happy to entertain those.
There is a new question.
Okay.
Let's do the chat. Best sleep aid for post-menopause.
Oh, good one. I get that one a lot. Yes, absolutely. I get that question. I think I might need to have some of that too. So for the best sleep aid for menopause, now, again, I think we all know you have to sort of go back again and try to get to the root of the problem. And so if it truly is hot flashes, night sweats that are keeping you up, that does sound hormonal, of course. And so we can use hormones for that. And sometimes if you just are on, say, an oral hormone, a patch, there are different ways to give hormones, of course. You may very well sleep better. I do get a lot of questions about herbal therapies. You know, most of our herbal therapies contain something like black cohosh or soy-based products. And so there are many of those over the counter. Some people just swear by those. If those really aren't helping, then we can talk about some sleep aids, such as prescription sleep aids. But usually, if it's because of menopause, those other ones will work.
Okay. Anyone else have any other questions? Nope. Okay, well, if nobody has any other questions, then we'll just wrap this up. And thank you for joining us.
Thank you very much.
And I hope you learned something new about cervical cancer, the screenings, everything that goes with being a woman.
That's right. All the things we have to do.
Yes.
Right. Thank you very much.
Yeah, and stay tuned for the next health talks, which will be Heart Month, and Dr. Rising will be talking. So hope you could join us then. Thank you, everyone.
Bye-bye.
Bye.